Hi everyone, my name is Francesca Cavallaro. I'm a maternal and child health epidemiologist at the UCL Institute of Child Health. This is presentation number 46, in which I'll be talking about using data linkage to assess the identification of vulnerabilities in administrative hospital data. So routinely collected administrative data can be useful because it captures information on vulnerable groups who tend to be at higher risk of adverse health and other outcomes, and who are also less likely to participate in primary research studies. However, the quality of administrative data for identifying these vulnerable groups is unknown. And by linking to service data containing more detailed information on vulnerability, we thought we could help better understand who is captured with the vulnerability indicators in administrative data. And to look at this, we are focusing on a cohort of young mothers who took part in the Family Nurse Partnership, or the FNP, which is an intensive home visiting program supporting young vulnerable mothers from early pregnancy until the child's second birthday. All first-time mothers who are aged under 20 at last menstrual period and who live in a local authority where the FNP is commissioned are eligible for the program. However, in practice, younger and more vulnerable mothers tend to be targeted for enrolment because the number of places is limited. And from a data standpoint, mothers participating in the FNP appear both in FNP service data and also most often in hospital admissions data, enabling us to compare what is recorded in both. And so the objective of our study was to examine the agreement between vulnerability indicators recorded in administrative hospital data on the one hand and FNP service data on the other, among young mothers aged 13 to 19 in England. So we used hospital admissions data from the Hospital Episode Statistics, or HES, to construct a cohort of all teenage mothers nationally who gave them birth in NHS hospitals in England between April 2010 and March 2019. HES contains linked information on hospital admissions, so we could also look at mothers' admissions before and after they'd given birth. We linked this information to FNP service data using a standard NHS digital deterministic algorithm, which was based on name, NHS number, date of birth, gender, and postcode. And we were able to identify more than 99% of mothers who'd taken part in the FNP in our HES cohort. The FNP data had a much broader range of information recorded on vulnerabilities, which was collected at enrolment in early pregnancy and at 36 weeks. So we restricted our cohort here to those who appeared in both FNP participants who appeared in both datasets. And we looked at the agreement between vulnerability indicators recorded in both data sources, both overall for all vulnerabilities and focusing specifically on mental health related vulnerability. Lastly, we compared the characteristics of mothers with an identified vulnerability in each data source and also the markers of severity of vulnerability. So for our vulnerability indicators, in administrative data, we used one indicator that our study group has used previously, which we've called adversity-related admissions. And now this is based on hospital admissions, which have an ICD-10 diagnostic code for mental health conditions, self-harm, substance misuse, or violence. And any mother who has any of these codes recorded within 2 years before 20 weeks of pregnancy is included in this vulnerability definition. And we use this definition because prior research in our group has shown that it's associated with a higher risk of adverse outcomes, including low birth rate and infant mortality after birth. In the FNP service data, we made use of a much broader range of vulnerabilities self-reported by the mothers, again, either at enrolment or at 36 weeks of pregnancy. This included a history of mental health concerns, reports of mental health service use during pregnancy, self-reported alcohol or drug use during pregnancy, physical or sexual abuse in the past 12 months, mothers who lived in residential care, foster care, or alone, and those who were involved with social services during pregnancy. As you can tell, these are not measuring the same dimensions of vulnerability. In fact, they're very different types of health service use, different timelines, and different conditions. So we didn't conceptualized the study as a validation of administrative data against an FNP service data gold standard, not least because the FNP service data is also self-reported, meaning that some mothers might not feel comfortable self-reporting vulnerabilities until they built up a better relationship with their family nurse, or they might have self-reported it at some point, but it would not get recorded at the specific time that this questionnaire is being filled out. Overall, we did think that sort of mothers who get admitted to hospital with one of these conditions might represent the more severe end of the spectrum, or the tip of the iceberg in terms of vulnerabilities, and that FNP service data vulnerabilities, because they were broader, would be relatively more common in our cohort. When we focused on mental health related vulnerability, we included in our administrative data vulnerability definition mental health conditions, self-harm and substance misuse, while in the FNP service data, we focused on mothers who'd self-reported mental health service use during pregnancy. We didn't include those with a history of mental health concerns here because there was no timeline specified for this, and we wanted to keep it relatively recent to within pregnancy. In terms of the severity criteria, we looked at severity markers recorded in FNP service data, so they'd be collected for all mothers in our cohort, not just those who had been admitted to hospital. And we focused on what we considered more severe conditions, which included moderate or severe depression and anxiety at 36 weeks, mothers who'd self-reported drug or alcohol use on at least 3 of the last 14 days, those who reported at least 3 instances of physical or sexual abuse in a past year, and those who were children looked after themselves during pregnancy. Again, conceptualizing this as a more severe vulnerability than a child protection plan, for example. So within our cohort, we had almost 29,000 mothers who were aged 13 to 19 at last menstrual period and who gave birth between our study within our study period. The median age at birth was 18. 83% of mothers were from a white ethnic background, and 50% of them lived in the most deprived quintile for area level deprivation. The Northwest London and the Southeast were the regions with the largest absolute numbers of teenage mothers. Now, when we looked at our definitions of vulnerability, we found that among all mothers in our cohort, more than half, or 57%, self-reported a vulnerability in the FNP data. There's probably an underestimate, again, because this is based on self-reports, and some mothers might not have self-reported a vulnerability that existed. Among the 57% who did have a vulnerability recorded in the FNP, 13% of them had an adversity-related admission in the 2 years before pregnancy, which is quite high, quite common, and much more common, in fact, than among mothers who did not have a self-reported vulnerability in FNP, which was only 5% in this group. If you look at all of the mothers with a HES vulnerability definition, so the 2 boxes of yellow dashed sections there, you can see that the vast majority of mothers who are captured in this HES definition are also included in the FNP vulnerability definition, meaning that the mothers we are capturing with this administrative data definition are by and large all vulnerable, and probably even a higher percentage of them are if they had self-reported accurately. When we focused on the mental health related vulnerabilities specifically, only 10% of mothers in our cohort reported using mental health services during pregnancy. And the numbers here, the total denominators, as you can see on the y-axis here, is smaller because this was information that was only started, that the FNP started to collect only sort of partway through our study period. So it's still relatively common, but less common than our previous definition of vulnerability. And when we focus specifically on those mothers who'd self-reported, one third of them had a mental health related hospital admission in HES in 2 years before they gave birth. So within this sort of more restricted group, a higher proportion of them have our definition of vulnerability as measured in hospital data. And only 10% of mothers who did not report mental health service use in pregnancy had such a prior related mental health admission in HES. So overall, you can see by looking again at the dashed yellow lines that in this case, the majority of mothers who are captured in our administrative data definition of vulnerability nonetheless do not report using mental health services during pregnancy. So again, it's a more select group, and so fewer of them match our FNP definition of vulnerability. When we looked at the characteristics of mothers who had an identified vulnerability in both data sources, we looked at these characteristics which are not per se markers of vulnerability, but they're often associated with high levels of vulnerability. And what we found was that in line with our hypothesis that mothers who'd had an adversity-related admission in HES, so our administrative data definition of vulnerability, tended to have characteristics suggesting that they were more vulnerable. So for example, a higher proportion of them were aged under 18 at birth, 50% versus 42% of those who self-reported a vulnerability in FNP service data. They were slightly more likely to be enrolled in the FNP after the sort of recommended 16-week cutoff, and they were more likely to have a multi-agency plan in place at the time of birth. However, they were equally likely to be receiving benefits at the time they gave birth. And lastly, slightly contrary to our hypothesis, a higher percentage of them had self-reported finishing school at the time they enrolled in the FNP, even though a smaller proportion of them were aged over 18. However, this might be that they had completed school because they had dropped out before the age of 18, while a higher proportion of vulnerable mothers, as defined in the FNP, was still enrolled in school at the time that they enrolled in a program. However, when we look at severity criteria, it tells us a slightly different story, in that actually, when we looked at these different severity criteria, there didn't seem to be many striking differences at all between mothers captured in both definitions of vulnerability. So virtually identical proportions of them had a moderate or severe depression score in late pregnancy. They were mothers who'd had an adversity-related admission recorded in HES were slightly more likely to be a child looked after during pregnancy, although the confidence intervals overlap on this. And they had very similar levels of sort of more severe substance misuse during pregnancy. The very bottom line here, looking at physical or sexual abuse on more than at least 3 occasions in a previous year, was one where there was evidence of a difference, but again, the magnitude of difference isn't very pronounced. So contrary to our hypothesis here, we find that actually they had quite similar severity levels. So perhaps both definitions of vulnerability, are capturing slightly different dimensions of vulnerability, but not necessarily more severe in one data source than the other. So to summarize our key messages, we found that linking administrative data with service data was useful for understanding which mothers are captured in indices of vulnerability based on administrative data. And this is useful because it can help us examine the impact of policies on these vulnerable groups. So it gives us a better idea of the strength of those methodologies. We found that vulnerability indicators in administrative data were much more common among mothers who self-reported a vulnerability in FNP service data. And by and large, when we use the adversity-related admission definition of vulnerability in hospital data, the overwhelming majority of mothers, and probably an even higher percentage if self-report was accurate, had self-reported a vulnerability. So we're satisfied that this definition does capture vulnerable mothers. However, it doesn't capture all vulnerable mothers, because most mothers who self-reported a vulnerability in the FNP data did not have a previous adversity-related hospital admission. And this makes sense in the sense that you wouldn't expect all mothers who are vulnerable to end up in hospital necessarily. And again, it suggests that this indicator captures the tip of the iceberg of vulnerable mothers, and not necessarily the most severe fraction of them. In terms of the implications for policy, I think it's important for researchers and policymakers who read these reports to remember that vulnerability indicators in administrative data probably are not accurate enough to identify all vulnerable individuals. It's important to try and keep in mind who might not be captured by these definitions. However, they do identify a subset of vulnerable mothers, which can be used to monitor trends and evaluate the impact of policies. And as long as this subset remains more or less constant, you can make some inferences and conclusions on this basis. However, it's also important to remember that particularly when you're looking at trends over time or after the introductions of policies, that how vulnerabilities are recorded in HES might in fact change who is captured in this definition of vulnerability, and reflect on these potential limitations in terms of interpreting any data trends. Thank you very much for taking time to listen to this presentation, and please don't hesitate to contact us if you have any questions or comments about this research. Thank you.